Hopefully that's not too loud. So my name is Josh Meier. I'm one of the members of Children's Orthopedics of Louisville. And so I just wanted a few quick announcements. Again, just make sure you please fill out your evaluations and turn those in. Those are obviously important for claiming your continuing education credit. We absolutely use those to plan the next symposium, get your feedback. We absolutely read those, look at them. They're very crucial to our planning for the next year and things like that. So we appreciate all the comments, those kinds of things. So please fill those out. And just a little quick reminder, it may have been announced in the morning that you do have access to the Ali Center as far as after the symposium if you want to go look at the exhibits, tour around. That's included as part of having the symposium here, so that's a great thing that they've done for us. So just to kind of let you know that. So we're going to go ahead and get started here this afternoon. I'm going to talk a little bit about lower extremity alignment, and I'm going to focus a little bit more, not so much on the rotational things, because that's been discussed a little bit, more so kind of the what we'll call angular deformities, so things like that, so normal versus abnormal. The objectives are to define and recognize patterns of development, know the typical patterns for changes in development over time and growth, and then understand the treatment options for pathologic alignment. So we know children's limbs are pliable. Their bones are fairly, we'll say, rubbery. They can bend, those kinds of things. So prior to walking, you may not notice a lot of either rotational or angular alignment issues because they're laying down, they're sitting. You may not see them until they become upright and they're more apparent. So that's when you usually get referrals for that or concerns for that from parents. So in order to diagnose abnormal, you really have to know what is normal. And so what is normal for rotational alignment? What is normal for angular alignment? So we'll start with when should kids walk? That's a very difficult question to answer, but in general, we would say roughly around a year would be probably typical, okay? We don't really worry about it as an orthopedic doctor till around 18 months, and I'll tell you that's a very soft age, okay? On their 18th month birthday, say, if they're not walking, that's not something that you have to be real concerned about, but it's just an age where we might kind of get a neurology evaluation, for example. Something like that may just make us think a little bit more. But again, it's not a hard and fast age. And usually, if they're not walking by that time, of course, we'll see them, take a look at them, make sure that they have the musculoskeletal parts to walk. But a lot of it can be developmental issues, and so we'll usually have our neurology colleagues also help us with that. So a lot of the alignment problems or non-problems we may see are due to interuterine positioning. So you can see here, this little baby's cooped up in here, and it's about time for them to be out, and their legs are folded and rotated and things like that, and so they develop that way over a period of time that keeps their bones and their muscles and things in a certain alignment and certain rotation that takes some time to unfold, and we'll hit that on a number of counts here. So that has an important influence on their rotational alignment. So this is more commonly what you see. Not so much this picture of this girl sitting this way, but a picture of this child sitting this way, that W sit. We'll see, it's okay. Usually by the 7th week of development, that lower limb is starting to internally rotate or rotate medially. And so that pretty much stays that way during development for the most part. So we talk about normal alignment. I know this x-ray got cut off just a little bit here, but this is the same child through a few years of growth and development. So a standing x-ray here at a little over a year of age shows a little bit of bowing, we'll say, and then it becomes a little straighter, and then say around age 4 or 5, it starts to become what we might call knock knees. And so this same child has different alignment changes with time. So when we talk about tibia vera, or we call bow legs, typically the maximum age by the textbook will be 6 to 12 months, and then usually resolving around 18 to 24 months, so typically by 2 years of age. This may persist a little longer in early walkers, and the question is if they're walking for a lot longer, if they start walking at age 8 months, maybe they're putting a lot of weight and gravity on these pliable bones, and it's more noticeable for a longer period of time if they start walking at 8 months, for example. So that's why maybe it may persist a little longer or seem to persist a little longer. Maximum valgus would be around age 4, okay? So the average adult alignment is about 8 degrees, and we'll see a diagram of that in a second here. And it's a gradual decrease in the valgus or the knock knees by typically age 11 is what we would say when they become more of adult alignment. So here's a chart that was published some years ago here looking at their age in years here, and then varus or valgus. So this is kind of, say, bow legs. So starting the average, when they're born, over 15 degrees, as they get to roughly around age 2, you can see that that alignment should be essentially neutral. They come into more of a, we'll call knock-knee position here, around the age of 4, and then gradually grow out of that as they go along. So that's where a lot of this information comes from, is just historic, normal studies of lots of children to come up with what is normal. So common angular concerns that we've kind of mentioned here, bow legs or knock knees. Genuvarum, genuvalgum are the doctor words. So bow legs is genuvarum. That means the knee is aligned toward the midline. That's what varus or varum is. And so you kind of get that cowboy appearance as they've come off the horse. That kind of looks like Max, but without the beard. So here's an example of a normal, say, child who's now of walking age, early walker, and you see this bowing of the legs. And you might even say, boy, that right one's a little bit worse than the left, okay? That is a very common normal alignment pattern in a young child who's just started to walk or who's been walking around, say, a year of age, 2 years of age. This is abnormal, okay? So you see this, you can tell this is a much older child. You can see significant, say, varus or angulation of the legs here, okay? And so sometimes it just takes a matter of just seeing lots of children and getting a sense of, oh, that's okay, or that's not okay. So a lot of that comes just with time and experience, but one of the things that can help you, again, is these normal ages. So same thing with valgus or knock knees. This is kind of a, say, preteen or young adolescent female who has some reasonable knock knees. Her knees touch together when she stands, her ankles are farther apart, okay? This is what I would still consider within a normal range of alignment. Now here's an abnormal example of valgus, okay? These are children with rickets, and so you can see significant valgus here to where I think you can kind of get a sense of that alignment is much different than this alignment. Even though the angles are similar and the direction is the same, it's a much more severe appearance. And so the thing to remember first is, in general, that it's okay. These variations are very commonly normal. That's how we were made. We were made to kind of have bow legs and knock knees and a variation of that. And so usually the history and exam, as we've seen all day here today, is enough to distinguish between normal and pathologic causes, but sometimes we need some imaging and things like that. So what I usually tell parents is children unfold as they grow. So there's some questions to ask, when you're examining these kids is this a variation of what we'll call normal alignment? Will it improve or will it worsen? We'll see a few examples of things that are not going to improve on their own, that they're going to worsen. And what's the functional impact? What is it now? What is it going to be later? A lot of parents have the concerns of, well, I don't want them to be like this and ruin their sports career, ruin their walking when 30 years from now. And we have the same concern, and it's just a matter of kind of counseling and education to make sure that they understand that most of these variations are not going to cause them long-term functional problems. So the history, how long has the deformity been present? Has it been present their whole life? Did they have an injury, a fracture? Did something, well, boy, they never had a bowed leg until a year ago when they broke their leg. Those kinds of things are important to know. Could they have a growth arrest, something like that? Do they have a family history? We'll talk about Blount disease in a minute, or like Dr. Jacks was talking about connective tissue disorders. Some of these things are hereditary, and so it's always important to know what their history is. And then their physical exam. We've gone over that a whole bunch today, so we'll kind of, I think, skip through that just a little bit. The neurologic status, their skin, do they have scars? Some of these kids come from we have a lot of military families that we see, and they've been treated at other institutions and things like that. They may have had some surgery, and it's, believe it or not uncommon for a parent or a caregiver to say, well, they had some surgery on their leg, but I'm not exactly sure what it was. And I've been surprised sometimes that they're not totally sure. So we'll start then with radiographs. As a referral center, we typically will take x-rays essentially every time when the child presents for in towing or limb deformity, even if we think in general it's normal. And sometimes that's just to prove to us and the family that it is, in fact, a normal variant or a normal alignment of childhood. You want to get these films in a standing position, because if you get them supine, they're not really going to have that same effect of gravity in their body weight. So they may look straight laying down. When you stand them up, they may have a lot of laxity, or the deformity may become worse. Sometimes you need, like this child here, you may need an individual. I know it doesn't project all that well because of the beautiful sunlight, but the alignment of the leg is such that you cannot get both of these legs on the same standing film. So you may have to just do one and then the other. You can assess a leg length difference, which Dr. Chan's going to discuss, I believe, here next, with a ruler or some other type of x-rays, which are not quite as important for looking at deformity necessarily. But one thing to remember is, and to know, is the normal anatomic alignment. I don't expect everybody to remember necessarily these numbers, but they do exist, and so you can kind of come up with some values of what the normal alignment should be, and it's fairly easy in the tibia and the ankle, because it's essentially a 90-degree angle, give or take a few degrees, and it's nearly 90 degrees at the proximal tibia. The one that I tend to just kind of use and remember the most is this lateral distal femoral angle here, which is about 81 degrees or so, and so that way you can just kind of assess what their individual limb alignment and bone alignment is. So the mechanical axis is one thing that we use, and this is, this is not a hard measurement to make. It's basically drawing it from the center of the hip to the center of the ankle and seeing where the body weight falls through the knee. And it should pass through the center of the knee in general, again, kind of past this 10, 11, 12 age range, okay? So here's an example of an x-ray where we can see, here's the normal line here on this drawing. You can see from this child here, center of the hip to center of the knee, his body weight and his alignment here falls outside of his knee joint, okay? And that's clearly not normal, especially at a nearly adult age, as you can, be nice if you could see the lack of growth plates there. But so bow legs. In general, again, this is normal, but there are a few conditions, namely Blount disease, which is what we're trying to avoid. Blount disease is a pathologic varus of the legs, named in Wisconsin, actually, by Dr. Blount. So it's very difficult to diagnose under age 2 years of age. So, age 2 years of age. When we see these kids, oftentimes we will tend to bring them back around age 2 if we see them early, because you really can't make that diagnosis very easily in the younger child, because there's not, the signs on the radiographs are really not valid until around age 2 or greater. And so if we see a child who's, say, a year of age for concerns of bowing, we'll definitely bring them back and we'll still evaluate them, but we really can't make any determinations till around age 2. So one of the ways we do that is with an angle we call the metaphyseal diaphyseal angle. It's also known as Drennan's angle. And basically you draw a line down the tibia, you draw a 90-degree perpendicular line to that, and then you draw another line that connects the lateral and the medial proximal tibia, this little pink line here. And so then you measure the angle between those, and here in this child's radiographs, that angle is 3 degrees, okay? Very normal angle. Contrast this, I'm sorry, we'll get there. So again, this usually resolves by age 2 to 3. Now, if you have a 3-year-old in the clinic, or this is, and we see them quite frequently, and if I say, well, this should be better by age 2, and they're 2 plus 1 day, there's some concern, right? So again, these ages are kind of, you don't want to fudge them too much because you don't miss pathology, but you want to just be a little bit careful saying, look, yeah, roughly around age 2, and I'll even say age 3 is kind of, this is still very typical. We'll still follow you, we'll check up on it, but kind of just, we tend to stay away from kind of real detailed concrete ages. Some of the differences here, and again, I know these x-rays may not project quite as well, but you do not have a lot of beaking of the tibia. In other words, you don't have a lot of sharp point of the tibia here. It's relatively flat up here, maybe a little bit of slope, but that's very normal. You have a little bit of curve of that distal femur that you typically see in a young child. And again, that metaphyseal diaphyseal angle is less than 10 degrees. Contrast that with this picture here of a child who has pathologic varus, okay? So we'll draw that same angle here. There's our 90 degree, and then we do that, and that angle is 17 degrees, okay? And so the other thing you notice here, I'll go back a little bit, is you see significant sloping of that proximal tibia. You see the growth plate itself is sloped downward, okay? So that is pathologic varus, and this child is closer to the age of 3.5, and that's not a normal appearance of the X-ray at that age. We'll skip through the drawing there. Okay, so this is Blount disease. It's a disorder of the proximal tibial physis here on the medial side, and we're not exactly sure what causes it. It tends to be unilateral most of the time, but it can be bilateral, and this is the one I still remember the question I missed way back as a resident on our in-training exam, that early surgery in general offers the best results. And I thought it was a trick question because you never do a big leg surgery on a 3-year-old, right? Well, that's what happens when you're a second-year resident, so then you learn. So after that, I became very interested in Blount disease. So as long as you learn from your mistakes, right? So here's an example of that same kid, and I keep hitting this instead of the green button. But here's their mechanical axis. Don't worry about this measurement here. We're just drawing that line, and you can see, again, that falls outside of the knee joint, where if you drew that same line on his right leg, it would fall relatively through the middle of the knee joint. And this is just a close-up view, again, of that proximal tibia that's just abnormal in appearance, again, compared to that where the physis is fairly horizontal. There's minimal sloping and beaking of the medial proximal tibia. So again, you can diagnose this roughly after age 2 to 2.5 years of age is when you can really start diagnosing it. You can try bracing. There is a role for bracing. Some of the braces that you see out there, you use a medial upright KAFO, or a Blount's brace is what it's called, and essentially it's a long leg brace with a metal stay that holds the leg in a little more of a valgus position, tries to get them out of that varus position. So you use that, and the problem with that is that oftentimes in order to give it a fair shot, you really need 8 to 12 months of bracing to really know for sure, is this working? The problem is that osteotomy, or cutting the bone and realigning the leg, is best done before around age 4. And that's been shown by some long-term studies. So you don't have a very long window of time if you want to try bracing to make sure you do your surgery in a timely fashion. So it becomes a little bit of a time-dependent treatment course. But if they still have that significant sloping and beaking and deformity of the leg, then absolutely we will do an osteotomy. We'll cut the proximal tibia, realign it, and let it heal. And that typically offers a very good result in a young child. Contrast that with physiologic varus, or normal alignment. So safely monitor every 6 to 12 months. Typically we will offer a follow-up appointment. Of course we'll keep an eye on it. We'll make sure it gets better. One of the reasons to do an x-ray is that we can document with that mechanical axis the improvement over time. And we can see it looks better. So a lot of times they see their kid every day. They may come back after 6 months or a year and say, I think it's still bowing, it's really not any better. And I can show them an x-ray from a year ago with that mechanical axis and say, but it is getting better. There's still maybe some angle there, but it's much better than it was a year ago. And that really helps. So now we'll talk about knock knees. Physiologic valgus, again, we saw that diagram there. So if you have progressive severe valgus like this, you may want to consider some of these other issues, endocrine issues, rickets, osteopenia, metabolic bone disease. Those are things that should be evaluated. There is not necessarily a Blount equivalent to valgus. There's just excessive valgus. So here you can see a pretty significant valgus here, where this mechanical axis again falls outside of the knee joint, and there's ways we can quantify in zones where the mechanical axis is falling within or outside the knee joint. And so one of the ways we can treat this is something called guided growth. So this is a little newer concept over probably the last 8 to 10 years. We can put a staple, or now more recently a plate, applied to the outer growth plate, and essentially it tethers the growth plate so it grows faster, say, on the lateral side than the medial side. And so these are designed then that you could remove them and theoretically allow normal growth to resume, which is fairly common. This is not an advertisement, it's generic plate. So here's an example of that, okay? Here's the mechanical axis. After treatment with some guided growth, you can see much improved mechanical access actually back through the knee joint. And so we can monitor that every 4 to 5 months with x-rays. So in conclusion, again, lower extremity alignment varies a lot during growth, so as long as you have a general sense of the ages and the range of what those variances are, you should be able to counsel and reassure parents and families that that's pretty much what's going to be the case. Luckily, Blount disease and things like that are fairly uncommon. Again, remember, bow legs usually resolves, again, generally age 2 to 3. Knock knees or valgus generally resolving around age 11 to 13. And so pathology is rare, but we don't want to miss it. So, you know, that's fine to have us take a look at any of those. So thank you very much.